Bismillahirrahmanirrahim. Now let's start with the cultosynthesis. My apologies for the background noise, if any, because I have tried to minimize that, but it is the fan that is running in the background. So if there is any background noise, I beg pardon for that once again. So moving forward to cultosynthesis. What is cultosynthesis? Cultosynthesis is the aspiration of fluid from the cul-de-sac of the Douglas rectouterine pouch. Okay, so I guess I have gave a wrong explanation to the cultosynthesis before that. Pardon me for that. So the cultosynthesis is aspiration of the fluid from the cul-de-sac of the Douglas to the rectouterine pouch by the needle puncture of the posterior vaginal fornix near the midline between the uterosacral ligaments. Okay, so remember this location that we are entering the syringe through the vagina, and then from the vagina, we are basically piercing the puncturing the posterior vaginal fornix near the midline between the uterosacral ligament to enter this pouch of Douglas, and then we take the aspirate from that. Because the rectouterine pouch is the lowest portion of the female peritoneal cavity, it is called as it can collect the inflammatory fluid in the pelvic abscess. So if there is pelvic abscess, so the fluid will be accumulated in the cul-de-sac because that is the lowest point of the peritoneum. So here you can see that this is vagina, and then fluid in the abdominal cavity is over there. Then we have the aspiration syringe and stuff like that. So derivatives of the primitive gut. So this is something that I was talking previously about. So let's see that in detail. So the foregut, it is giving rise to esophagus, stomach, duodenum first and second part, liver, pancreas, biliary apparatus and the gallbladder. Midgut gives rise to duodenum second, third and fourth parts, jejunum, ileum, cecum with appendix, ascending colon, transverse colon, proximal 2/3, and for the hindgut, transverse colon, distal 1/3, descending colon, sigmoid colon, rectum, inner canal above the pectinate line. So remember these derivatives. Moving forward, so these are the arterial supply and the nerve supply. Yeah. So these are some neurovascular structures of the foregut, midgut, and hindgut. So foregut, the arterial supply is coming from the celiac artery. The parasympathetic innervation is the preganglionic and is divided into preganglionic and postganglionic segments. The preganglionic segments for the foregut are coming from the dorsal motor neuron of the vagus, that is CN10, cranial nerve 10, and the postganglionic ones are coming from the terminal ganglions. The sympathetic innervation is from the preganglionic one is coming from the intermediolateral columns from T5 to T9. The greater splanchnic nerve, I don't know what NN means, greater splanchnic neuronal network, I guess. Then postganglionic nerves originate from the celiac ganglion. The sensory innervation is the the dorsal root ganglion T5 to T9, and referred pain is to the epigastrium, as we previously have seen in the last session. Midgut, the arterial supply is coming from the superior mesenteric artery. The parasympathetic innervation is the preganglionic, again coming from the dorsal motor neuron of the vagus nerves, cranial nerve 10, and the postganglionic is from the terminal ganglia, which are located most often on the target organs. Then the sympathetic innervation, the preganglionic is coming from the intermediolateral horns from the T10 to T11. Lesser splanchnic neuronal network, and then okay, then postganglionic is superior mesenteric ganglions. Sensory innervation is from the dorsal root ganglions T10 to T11, and referred pain is to the umbilical region. Then we have the hindgut. The artery of the hindgut is inferior mesenteric artery, IMA. Parasympathetic innervation is different in this case. The preganglionic fibers are coming from the splanchnic parasympathetic nervous system. So splanchnic pelvic nerves. I'm sorry, these are splanchnic pelvic nerves. So splanchnic pelvic nerve S2 to S4 and pelvic splanchnic neuronal network. Postganglionic or terminal ganglion. Okay, the sympathetic innervation is preganglionic intermediolateral horn of L1 to L2, lumbar splanchnic neuron network. The postganglionic inferior mesenteric ganglion. The sensory innervation, the dorsal root ganglion L1 to L2, and the referred pain is to the hypogastrium. Posterior gastric ulcers. Okay, so remember about the posterior gastric ulcer, I guess they're over there. So posterior gastric ulcer may erode through the posterior wall of the stomach into the omental bursa, that is lesser peritoneal sac. So just behind the stomach we have the lesser peritoneal sac. It can affect the pancreas, resulting in the referred pain to the back. So if there is some gastric ulcer which is present on the posterior wall, like over here, it can erode and the gastric contents will enter the inferior omentum, the lesser omentum. So when it will enter the lesser peritoneal sac or lesser omentum, after entering that, the pancreas is also located just behind that over there. This is the pancreas. So if the pancreas is damaged or inflamed, so resultantly there will be pancreatitis, and that pancreatitis will cause what? That will cause the referred pain that is radiating to the back. Okay. Erosion of the splenic artery is very common in the posterior gastric ulcers as well as because of the proximity of the artery to this wall, and then that will lead to hemorrhage. What is Meckel's diverticulum? It is very important as far as the GIT section is concerned, and right now as we are doing the abdominal anatomy, so that is also important in the GIT section. So let's read that. Meckel's diverticulum is a congenital anomaly representing the persistent portion of the vitello-intestinal duct connection from the midgut to the yolk sac incorporated into the umbilical cord. Normally degenerates at 2 to 3 months of gestation. This condition is often asymptomatic but occasionally becomes inflamed if it contains ectopic gastric, pancreatic or endometrial tissue, which may produce ulcerations. Meckel's diverticulum is located on the ileum about 2 feet, that is 61 cm before the ileocecal junction, and the superior mesenteric artery supplies it. Superior mesenteric artery is going to supply the Meckel's diverticulum because it is most commonly present in the midgut derivatives, that is ileum. It occurs in 2% of the patient and is about 2 inches long. So this is the rule of 2, like 2 feet from the ileocecal junction. 2% of the patients are affected and 2 inches long in length. Okay, the diverticulum is clinically important because the diverticulitis, liberation, bleeding, perforation, and obstruction are complications requiring surgical intervention and frequently mimicking the symptoms of acute appendicitis. And another thing about it, that it is a true diverticulum, which means that all the 3 layers of the GIT lining will be herniating, or not herniating per se, will be outpouching. So in a post diverticulum, for example, the Zenker's diverticulum that is present in the upper esophagus, in that particular area, only the mucosa and submucosa is herniating outwards, but the muscularis is right on its place. It is not outpouching. But in the case of Meckel's diverticulum, all the 3 layers, that is mucosa, then submucosa, along with the muscularis, they are all of the 3 layers are pouching outwards, and they are creating a true diverticulum that we call Meckel's diverticulum, present over here in the picture. Then we have point number 39, that is about the features of large intestine. So let's look at them. The features of large intestine are appendices epiploic. What are that? Appendices, I guess these are the mental appendices. These are the like mental projections, so you may see that yellow projections coming out of it. So these are appendices epiploic, seculations or house stations, like this one, like this. These things are called seculations or house stations, which are because of the contraction of tinea coli and then tinea coli. The tinea coli meet together at the base of the appendix, where they form a complete longitudinal muscle cord of the appendix. Okay, but otherwise there are like 3 strands, like there is 1 strand over there and there are 2 others. So the contraction of these tinea causes the formation of these house stations. So appendices epiploic, circulation, which are house stations, and the tinea coli. Then here we have the house of the colon and then tinea coli over there. Then we look at the colon. What was that? So these were the features of large intestine. Large intestine is basically majorly its colon. But now look at it individually. So colon is divided into 3 segments. The ascending colon lies retroperitoneally, lack a mesentery. So there is no mesentery to the ascending colon, and this one is the ascending colon, and it lies retroperitoneally without a mesentery. It is continuous with the transverse colon at the right hepatic flexure. So this is the right hepatic flexure. It is continuous with that. Okay, right over the hepatic flexure. There is only one hepatic flexure, that is the right flexure of the colon. The transverse colon, this is over here. So this transverse colon has its own mesentery called as transverse mesocolon, and that is an intraperitoneal position. So the transverse colon is the intraperitoneal structure. So I guess that will be not be significant over here. But let me make it yellow. The greater omentum that is present on the lesser wall of the stomach, it moves downward, and then it reflects upwards, and then it covers the transverse colon. So transverse colon, that is why it's intraperitoneal, because the greater omentum, reflection of the greater omentum is covering it, and that thing is called as the gastrocolic ligament, I guess, between the stomach and the colon. So that thing is also present. It's not mentioned here, but remember that. So the first part of the ascending part is retroperitoneal. The second part, the transverse colon, that is intraperitoneal. Then it becomes continuous with the descending colon at the left splenic flexure over here. It is also called as the Griffith point. So in this splenic flexure, it becomes continuous with the descending colon, right? The sigmoid colon is suspended by it becomes continuous with the descending colon at the left splenic flexure of the colon. The sigmoid colon is suspended by the sigmoid mesocolon intraperitoneal position. So the sigmoid colon is also intraperitoneal. I don't know about the descending colon. I guess it is also retroperitoneal. But the sigmoid colon is suspended by the sigmoid mesocolon, and that is intraperitoneal in position. Moving to the appendicitis, that's the point 40. In appendicitis, the first pain is referred around the umbilicus. Visceral pain in the appendix is produced by the distension of the lumen or the spasm of the muscle. So the visceral pain is produced due to 2 reasons. First one is the distension of its lumen that causes the distension of the parietal peritoneum. or secondly there can be there can be spasm of its muscle that causes the uh, production of visible pain. I'm sorry. So the afferent pain fibers enter the spinal cord at the level of T10 segment, and a vague referred pain is felt in the region of the umbilical dermatome, or in the region of umbilicus, that is T10 dermatome, because it is a structure coming or originating from the midgut. So the referred pain is going to the umbilicus, right? Later, if the parietal peritoneum gets involved and the pain is then the pain is shifted to the shifted laterally to the McBurney point. Here, the somatic pain is precise, severe, and localized. It is called as the second pain. So first pain is in the umbilical region, while the second or the referred pain goes to the McBurney point. Then we have McBurney point over here. So you can see McBurney point is right where they have written 1. So the point indicates the surface marking of the base of the appendix. McBurney point 1 is at the point of junction between the lateral 1/3 and the medial 2/3 of the line joining the right anterior superior iliac spine with the umbilicus. So suppose here we have the right anterior iliac spine, ASIS. So that ASIS, if we connect that with the umbilicus, so the line, the point that is joining the medial 2/3 and the lateral 1/3, that point is called as the McBurney point, and this refers to the base of the appendix. So here you can see it that so there can be a lot of positions, a lot of different positions to appendix. Here it is the periileal, then it is postileal, pelvic, subcecal, so and then retrocecal. So these are the position of appendix, and these are normal physiologic position. In pathologic conditions, suppose we have a malrotation of malrotation of GAT, the malrotation of midgut. Yeah, if there is midgut malrotation, so there will be an undescended cecum, and the pelvic and the appendix is present over here in the right hypochondriac region. So the pain of the appendix will also be felt over there. So retrocecal is the most common position of the appendix, like second one. So the retrocecal position is the most common position of the appendix. That is 2 times more common than any other position, I guess. Then the volvulus. Because of extreme mobility, long mesentery, the jejunum, ileum, and the sigmoid colon sometimes rotate around its mesentery. The volvulus results in avascular necrosis corresponding part of the intestine. Okay, so corresponding to the part of intestine. So suppose this is the mesentery containing the blood vessel, and here we have the lumen, or here we have the freely mobile viscera. That freely mobile viscera sometimes rotates along, it curves around its own mesentery and strangulates itself. Resultantly, there will be a volvulus. So volvulus result in the avascular necrosis corresponding of the corresponding part of the intestine. This may correct itself spontaneously, or the rotation may continue until the blood supply of the gut is cut off completely. This may correct itself spontaneously, or the rotation may continue until the blood supply of the gut is cut off completely. Okay, and the intestinal segment dies out. The point number 42 is about Hirschsprung disease. So it is a rare congenital anomaly that results in the intestinal obstruction of the megacolon because of congenital absence of the postganglionic parasympathetic neurons. Okay, there is congenital absence of the postganglionic parasympathetic neurons, terminal ganglia, mesenteric plexus inside the wall of large intestine. Reasons of defective migration of the differentiation reason is the defective migration or differentiation of the neural crest cells. It is commonly found in the Down syndrome children. In a newborn, the chief sign and the symptoms are failure to pass meconium stool within 24 to 48 hours after birth, reluctance to eat, bile sustained green vomiting, and the abdominal distension. Treatment is removal of the aganglionic portion of the colon. Then we have branches of the abdominal aorta and the mesenteric ischemia. So we are talking about these things. First we will talk about celiac trunk, originate from the aorta at the lower border of T12 vertebra. Superior mesenteric artery originates at the lower border of L1 vertebra. Renal arteries originate at approximately L2 vertebra. Then inferior mesenteric artery originates at L3 vertebra. 2 terminal branches of common iliac artery originate at L4 vertebra. Let's repeat that. So celiac trunk is originating at this level, that is T12. Okay, which means right after the aorta is coming out of the aortic hiatus of the diaphragm. Immediately after that, the celiac trunk originates at the level of T12. The superior mesenteric artery is originating just below the celiac trunk at the level of L1 vertebra. Okay, then after that, on each side there will be renal arteries that will be coming out. Okay, then we have the renal arteries and inferior mesenteric artery. The inferior mesenteric artery is coming at the level of L3. So between the superior and inferior mesenteric artery, we have L2 vertebra. So this is a point. Listen it. If you understand this, keep it with you. If you don't understand that, forget everything about this point. There is a thing that we call horseshoe kidney. So horseshoe kidney is the kidneys basically develop in the pelvis and then they ascend in the intrauterine life. If there is horseshoe kidney in which the inferior poles of the two kidneys are joined together, that horseshoe kidney is stuck in the inferior mesenteric artery, and we say that it is lying in the lower level because inferior mesenteric artery got the kidneys, and that is why they are in the lower position. So if the celiac trunk, if the superior mesenteric artery is the level of L1, is at the level of L1, and the horseshoe kidney is stuck in the inferior mesenteric artery, so it means that these arteries are definitely superior to the inferior mesenteric artery. So imagine it in your mind that the renal arteries or the kidneys are present between the superior and inferior mesenteric artery. So if the superior mesenteric artery is coming at the level of L1, so the renal arteries must be at the level of L2 and inferior mesenteric artery at the level of L3, so that the kidneys are between the superior and inferior mesenteric artery in the physiologic position. So this is how I remember that. If you want to forget it, please do forget it, and then let's move on. So inferior mesenteric artery at the level of L3 vertebra. Then two terminal branches are common iliac arteries, which are L4 vertebra over this. So the bifurcation occurs at L4. Okay. Then we have celiac artery or the trunk. I guess there was some bifurcation of the trachea, the T4. If I'm not wrong. If I am not wrong, I guess there's a bifurcation of trachea T4 as well. So let's move on. So celiac artery or trunk. The region T12, just below the aortic opening of the diaphragm. The celiac artery passes above the superior border of the pancreas and then divides into three retroperitoneal branches that are left gastric artery, common hepatic artery, and splenic artery. The common hepatic artery is just for the theoretical or hypothetical purposes. As a matter of fact, when we talk practically, the only we say hepatic artery. So here you can see the first one is the left gastric artery. Okay, let me change the color because everything is red over there. So this artery over here, it is the left gastric artery. The second artery, this one is the common hepatic artery, and the third one is the splenic artery over here that is going all the way into the spleen like that. After that, we have left gastric artery, which is a branch of celiac artery. So the left gastric artery over here, this one, the left gastric artery crosses upwards to the left to reach the lesser curvature of the stomach and may be subject to erosion by a penetrating ulcer. The left gastric artery. Okay, so if you can see the pathway of left gastric artery, so this is left gastric artery which is coming down on the lesser curvature of stomach. So this particular artery, the left, it reaches upward to the left, to reach the lesser curvature of stomach and may be subject to erosion by the penetrating ulcer by the lesser curvature. So by now we have seen two things. Firstly, if there is an ulcer on the lesser curvature, that can cause damage or that can cause hemorrhage from the left gastric artery. Or if there is an ulcer on the posterior gastric wall, if I could go some pages up above, so there we saw that if there is ulcer on the posterior abdominal wall or the posterior gastric wall, so that ulcer can erode its content into the lesser peritoneum, and that eroded content will then ultimately lead to the damage to the pancreatic artery over here. No, splenic artery. Oh, I'm sorry, splenic artery, and ultimately they will be bleeding from the splenic artery. Erosion of the splenic artery will be there if there is posterior gastric ulcer. Coming back to the point. Over here, okay, yep. So over here, the branches are esophageal branches to the abdominal part of the esophagus. Okay, so the left gastric artery provides abdominal branches to the esophageal branches to the abdominal part of aorta. Then the gastric branches supply the left side of the lesser curvature of the stomach and make anastomosis with the right gastric artery. So the right gastric artery is over here, right over here. The right gastric artery is like this is the left gastric artery, and the right gastric artery which is coming from the proper hepatic artery that will be supplying this artery. Then we have common hepatic artery, like this one. This is the common hepatic artery. So the common hepatic artery passes to the right, reaches the superior surface of the first part of duodenum, where it divides into two terminal branches. That is proper hepatic artery, which will move upward like this. This is proper hepatic artery, and the gastroduodenal artery, which will come down like this. Then we have proper hepatic artery. So proper hepatic artery gives rise to the right gastric artery. Like this is the right gastric artery going to the right side. This one. Okay, so this is the right gastric artery, and it is the left gastric artery. Okay, so right gastric artery and then ascends within the hepatoduodenal ligament of the lesser omentum to reach the porta hepatis, where it divides into right and left hepatic arteries. Okay, proper hepatic artery gives off right gastric artery. Pardon me. So the proper hepatic artery is giving the right gastric artery, which is moving like that, and then it ascends into the gastroduodenal ligament to give these right and left hepatic arteries. Okay. The right and left arteries enter the two lobes of liver. The right hepatic artery gives cystic artery to the gallbladder. So here you can see the cystic artery going to the gallbladder over there. This is cystic artery. This can either come from the proper hepatic artery or can also come from the right hepatic artery. The right gastric artery supplies the right side of the lesser curvature of the stomach, where it anastomoses with the left gastric artery So again, the left gastric artery is coming from here, and these two anastomoses of the lesser curvature of the stomach. Then what about gastroduodenal artery? So this is the gastroduodenal artery. If I could zoom it in, so here you can see the gastroduodenal artery, which is coming from the hepatic artery proper and descending behind the duodenum. So this gastroduodenal artery descends posterior. Okay, give me a second. Yep. So gastroduodenal artery descends posterior to the first part of the duodenum, may be subject to erosion by the penetrating ulcer in this place, and divides into two branches. So the gastroduodenal artery can be subject to erosion of the duodenal ulcer. Remember this point, that on the lesser curvature, the left gastric artery is subject to erosion by the gastric ulcer, and the gastroduodenal artery is subject to erosion by the duodenal ulcer if it is present on the posterior wall of the duodenum. Then in this place, and divides into two branches. The right gastroepiploic artery supplies the right side of the greater curvature of the stomach, where it anastomoses with the left gastroepiploic artery. So here you can see that the gastroduodenal artery is dividing into the right gastroepiploic artery, right, which will anastomose here with the left gastroepiploic artery, which is coming from the splenic artery. So they will come and anastomose at the greater curvature. And the second branch is superior pancreatico-duodenal artery, supplies the head of pancreas. Superior pancreatico-duodenal artery will be like, I guess, coming into, where is that? So superior pancreatic head is over there. This is the pancreas. So the pancreatic head will be supplied by superior pancreatico-duodenal artery, that is coming from the gastroduodenal artery, a branch of the gastroduodenal artery. It supplies the head of pancreas, where the anastomose in the inferior pancreatico-duodenal artery from the superior mesenteric artery. Superior pancreatico-duodenal artery supplies the head of pancreas, where they anastomose on the inferior pancreatico-duodenal arteries. Where the anastomose with the inferior pancreatico-duodenal arteries from superior mesenteric artery. So superior pancreatico-duodenal artery on the pancreas will be anastomosing with the inferior pancreatico-duodenal artery, which are coming from the superior mesenteric artery. Remember this point, because I'm having a hard time remembering that. Okay, so ligature of the hepatic artery. The hepatic artery may be ligated proximal to the origin of its gastroduodenal branch. A collateral circulation to the liver is established through the left and right gastric arteries, the left and right gastroepiploic and the gastroduodenal arteries. So how do we ligate that? We are ligating it over here. So the hepatic artery may be ligated proximal to the origin of the gastroduodenal branch. A collateral circulation to the liver is established through the left and right gastric arteries. So these are the left and right gastric arteries. We can establish a circulation. We can establish a collateral circulation with that. And then so left and right gastric arteries, left and right gastroepiploic arteries, and the gastroduodenal arteries. The right hepatic artery may be mistakenly ligated during the cholecystectomy. What's that? I guess the removal of whole gallbladder. Let's see that. Cholecystectomy. That is cholecystectomy. There's nothing like cholecystectomy. It is cholecystectomy, and the Google is not correcting me. It is cholecystectomy. Okay. So what is cholecystectomy? Cholecystectomy is the surgical removal of the gallbladder. So when we are doing the surgical removal of the gallbladder, we can inadvertently or mistakenly ligate the right hepatic artery in the Kellett's triangle. So the triangle they have drawn, this is called the Kellett's triangle. There are some boundaries of that if they have written that. Kellett's triangle together with the cystic artery and right lobe of hepatic necrosis, and right lobe hepatic necrosis commonly occurs. So if in the Kellett's triangle during cystectomy we cause the ligation of the right hepatic artery, so definitely there will be obstruction, or there will be necrosis of the right hepatic lobe, because the right side of the liver is being supplied by the right hepatic artery. Moving forward to the splenic artery. So here we have the splenic artery, this one, that is coming directly from the celiac artery. The splenic artery runs tortuous horizontal course to the left along the upper border of the pancreas behind the peritoneum of the posterior wall of the lesser sac, forming a part of the stomach bed. Okay, it is forming a part of the stomach bed, which means that the structures on which the stomach is lying, they will be forming the stomach bed. So one of the structure which is forming the stomach bed is the splenic artery. The splenic artery may be subject to erosion by the penetrating ulcer on the posterior wall of the stomach, as we previously have seen, into the lesser sac. Note, splenic vein runs a more straight course below the artery and behind the pancreas. So it is running a tortuous course, but the splenic vein will go straight. Right? Splenic vein runs a more straight course below the artery behind the pancreas. Then we'll talk about splenic artery again. We are continuing our discussion on splenic artery. So splenic artery is over here. Number one is retroperitoneal until it reaches the tail of pancreas, where it enters the splenorenal ligament to enter the hilum of spleen. So the pancreatic tail is the only part of the pancreas that is intraperitoneal. So splenic artery is also retroperitoneal until it reaches the tail of pancreas, where it enters the splenorenal ligament to enter the hilum of spleen branches. I guess the splenorenal ligament is a part of peritoneum. if I'm not wronging or confusing myself, so the sphenorenal ligament is a part of peritoneum. Do check it out, guys. So branches to the spine. Okay, the branches are branches to the spine. Splenic, definitely splenic artery. So definitely is supposed to give branches to the spine. Then it will give branches to the neck, body, and the tail of pancreas. Left gastroepiploic artery that supplies the left side of the greater curvature of the stomach, where it anastomoses with the right gastroepiploic artery. So it is going to give the left gastroepiploic artery over here, which will anastomose with the right gastroepiploic artery that was coming from the gastroduodenal artery on the greater curvature of the stomach. Then we have short gastric arteries, 5 branches. Pardon me, the short gastric arteries over here. These are the short gastric arteries. So branches that supply the fundus of the stomach. These are the short gastric arteries. Then we are going to talk about the superior mesenteric artery and its branches. So superior mesenteric artery over here, that is originating at the level of L1. Okay, so superior mesenteric artery will give rise to inferior pancreatico-duodenal artery, which will anastomose with the superior pancreatico-duodenal artery, and superior pancreatico-duodenal artery was originating from the gastroduodenal artery, which was coming from the common hepatic artery. So let's see that. Too many arteries. So it was like over here, I guess, gastroduodenal artery. It was giving rise to superior pancreatico-duodenal artery, and there we saw that it was going to anastomose with the inferior pancreatico-duodenal artery, which would be originating from superior mesenteric artery, and we will see that later on. And now let's see that. In this picture, you can see that the inferior pancreatico-duodenal artery, which is over here, it is going upward and it will anastomose with the superior pancreatico-duodenal arteries. Then number 2 is jejunal and the ileal branches. So number 2, these are the jejunal branches, like a lot of them. These are jejunal branches, and also the ileal branches, which are on number 3. Like here we have the ileal branches. Point number 4 is ileocholic artery. So over here we have the ileocholic artery on number 4. Where is that? This is the ileocholic artery. So the ileocholic artery, ascending branch, anterior cecal artery. Ileocholic artery, ascending branch, the anterior cecal artery, the posterior cecal artery, and also from the ileocholic artery we get the appendicular artery. That is very important, but there is a sub branch of the ileocholic artery. So here we are getting the appendicular artery, like this artery. Give me a second. Yeah. So there's a appendicular artery that's coming all the way down to the appendix over here. So this artery that is coming from the ileocholic artery. Then the right cholic artery and the middle cholic artery. Okay, so right and middle cholic arteries are also coming from this. So it is supplying basically it is supplying the pancreas partly. Along with that, it is also supplying the second and third part of the duodenum and the jejunum and ileum, then the ascending colon and then the transverse colon until the proximal 2/3 of it. So here is the middle cholic artery, and it was like ascending colon or the right cholic artery, because ascending colon is on the right side, so we call it right cholic artery. Then we have inferior mesenteric artery and its branches. So the inferior mesenteric artery gives rise to the left cholic artery, because it has to supply the descending colon. So number 1 artery, this is the left cholic artery, and the sigmoid arteries, number 2, that is over here. So these are the sigmoid arteries, like these, all of them are sigmoid arteries which are coming to supply the sigmoid colon. And then superior rectal artery, which is over here, like this is the superior rectal artery, which is supplying the superior part of the rectum. Note, the branches of superior mesenteric artery and inferior mesenteric artery to colon are interconnected by a continual arterial arch, marginal artery of Dermont. What's that? The superior and inferior mesenteric artery to the colon are interconnected by a continual arterial arch that is called as the marginal artery. I saw marginal artery written over here, I guess. Where is marginal artery? There's no marginal artery written over there. So, but there is a marginal artery of the Dermont. It provides collateral circulation between two parts of the large intestine and prevent the mesenteric ischemia. So there is a very good collateral supply between the intestines. So let's see the marginal artery of Dermont. The marginal artery of Dermont. Marginal artery of Dermont. So marginal artery of Dermont is an anatomically viable blood vessel that forms a major anastomotic network between the superior and inferior mesenteric arteries, and the image of that marginal artery is like over here. So meandering artery, this is MA, the marginal artery. So this continuous artery from here all the way moving upwards, and then this one and this one. So this is the marginal artery of Dermont. So remember this thing, and then we'll move forward to the next part of the PDF, next page, I guess, next point. So next, no, it's mesenteric ischemia. Here is the continuation, this same point. So mesenteric ischemia, atherosclerosis, which slow the amount of blood flowing through the arteries, is a frequent cause of chronic mesenteric ischemia Ischemia occurs when the blood cannot flow through the arteries as well as it should, and intestines do not receive the necessary oxygen to perform normally. Mesenteric ischemia usually involves the superior mesenteric artery and the small intestine. Mesenteric ischemia primarily affects the organ which locate far away from the anastomosis, with what's that, celiac artery and inferior mesenteric artery. So mesenteric ischemia primarily affects the organ which locate far away from the anastomosis, with celiac artery and the inferior mesenteric artery. Usually the blood supply of the jejunum and ileum is most compromised because these two are highly functional organs. Like there is a lot of absorption going on in these regions. So the blood supply of the jejunum and ileum is most commonly compromised. Mesenteric ischemia typically occurs in the people older than age 60 with a history of smoking and high cholesterol level. So this is stomach and large intestine and abdominal aorta, and if there is obstruction in the abdominal aorta, so there will be ischemia of the ileum and jejunum definitely, because celiac artery and inferior mesenteric artery will be blocked. What's that? I don't know. So moving forward, we have biliary system. Point number 44 is about the biliary system and the gallstones. So the bile is secreted by the liver cells, stored and concentrated in the gallbladder, and later it is delivered to the duodenum. So here we can see the gallbladder. The function of gallbladder is to store and concentrate the bile and then to release it into the duodenum by the cystic duct, which goes to the common hepatic duct, and then hepatic duct is met with the main pancreatic duct, and both of them enter in the descending part of the duodenum, the second part where there is major duodenal papilla or the ampulla of Vater. The gallbladder lies in the its fossa. What's that fossa? In the itis fossa or its fossa. What's that? On the visceral surface of the liver, right side of the quadrate probe. Let me see its fossa. What's that? Its fossa. So the its fossa is a thing. It's a real thing. So it is infratemporal fossa, but no, we are not talking about that. Its fossa for the gallbladder fossa. Okay, so it's not its fossa. Its fossa is nothing. They're saying that gallbladder lies in gallbladder fossa. So gallbladder lies in its fossa. On the visceral surface of the liver, right side of the quadrant lobe, it stores and concentrates the bile, which enters and leaves it through the cystic duct. Okay, the cystic duct joins the common hepatic duct from the left and right hepatic duct from the right hepatic ducts to form the common bile duct. So cystic duct is joining the common bile duct, which in turn is formed due to the fusion of right and left hepatic duct. So right and left hepatic duct fuse to form common hepatic duct, which causes the fusion of cystic duct to form the common bile duct, and then common bile duct will cause the fusion. Will have a fusion from the main pancreatic duct to cause the release of both the pancreatic and the biliary secretion into the duodenum. Then what is biliary system? The common bile duct part of the portal triad descends into the common bile duct. Okay, the common bile duct part of the portal triad descends in the hepatoduodenal ligament, then passes posterior to the first part of duodenum. It penetrates the head of pancreas, where it joins the main pancreatic duct, and they form a hepatopancreatic ampulla, which terminates in the sphincter of Oddi. It drains into the posterior medial wall of the second part of duodenum at the major duodenal papilla. So this is the major duodenal papilla, and here we can see the common bile duct that is descending into the that is descending in the hepatoduodenal ligament as a portal triad. Then it passes behind this, the first part of duodenum into the head of pancreas, and then all the way. This is minor duodenal papilla over there, and then we have accessory pancreatic duct and hepatopancreatic ampulla over there, and major duodenal papilla. Then what is cholelithiasis of the gallstones? So the distal end of the hepatopancreatic ampulla, the common bile duct, is the narrowest part of the biliary passage. What? The distal end of hepatopancreatic ampulla. This is the distal part of the hepatopancreatic ampulla, like I guess over there. The distal part is the narrowest part of the biliary passage and the most common site for the impaction of gallstones. As a result of common hepatic, number one, this is common hepatic bile duct. Common hepatic duct is over here. This is common hepatic duct. Then we have the bile duct number 2. Then the duodenal papilla, that is number 3. This is the duodenal papilla. Obstruction, patient will have yellow or icteric sclera and jaundice. So there will be jaundice if the biliary duct flow is obstruction. So if there is duct flow obstruction, so there will be jaundice, and that jaundice will be due to direct hyperbilirubinemia. Gallstone may lodge in the cystic duct. A stone lodged in the cystic duct. Okay, so they have shown us, where have they shown it? On the 4. So there is maybe a stone that is lodged in the cystic duct over here. Causes the biliary colic, intense spasmodic pain of the gallbladder, but does not produce jaundice. So if there is obstruction over here, so it will cause just intense pain, but jaundice will not be there. If there is pain, if there is obstruction from 1 all the way to 3, so there will be jaundice. But if there is obstruction in the gallbladder neck, so there will be spasmodic pain only. The jaundice will not be seen. Why will there be spasmodic pain? Because if it is obstructed over there, the peristaltic waves of contraction are coming, and they will contract against the stone, and there will be, pain, spasmodic, colicky pain. And if the stone falls back into the gallbladder, the pain will be gone. So this is the concept of spasmodic pain, and there will be no jaundice. Talking about gallstones, here you can see the gallstones. So the fundus of gallbladder is in contact with the transverse colon. The fundus of gallbladder is in contact with the transverse colon. Thus, the gallstone erode through the posterior wall of the gallbladder and enter the transverse colon. They are passed naturally to the rectum through the descending colon and the sigmoid colon. The gallstone lodged in the body of gallbladder may ulcerate through the posterior wall of body of the gallbladder into the duodenum. So if they are damaging the if they're entering the transverse colon, so there will be no problem, because that stone will be passed all the way into the the from the intestine into the that will pass into the stool. But if there is some stone that is entering the duodenum, the first part of duodenum, pardon me, I'm sorry. If that is entering the transverse colon, there is no problem. But if it is entering the duodenum, there is big problem. What is that problem? The gallstone lodged in the body of the gallbladder may ulcerate through the posterior wall of the body of the gallbladder into the duodenum, because the gallbladder body is in contact with the duodenum and may be held up at the ileocecal junction, because ileocecal junction is the narrowest point of the intestine, I guess. So ileocecal junction, the stone will be stuck there, and that will cause intestinal obstruction, and that will present with the gallstone ileus. Now we'll talk about the nerve supply of the liver and gallbladder. The sensory innervation of liver by the right phrenic nerve C3 to C5, pain may radiate to the right shoulder. So if there is any problem going on with the liver or mainly the gallbladder, so the pain will be radiating all the way to the right shoulder. The liver receives the parasympathetic innervation from the vagus nerve C and 10, reaching it through the celiac plexuses around the supplying arteries. The preganglionic fiber synapse from the cell of the terminal ganglia in the hilum of the liver, and short postganglionic fibers supply the organs. Liver receives the parasympathetic innervation of the vagus nerves, okay, reaching it through the celiac plexus around the supplying arteries, which is basically a celiac trunk. So sympathetic fibers will come along the celiac artery, and they will be supplying that. Okay, got it. Around the supplying artery, the preganglionic fiber synapse on the cells of the terminal ganglia in the hilum of the liver, and short postganglionic fibers supply the organs. So postganglionic fibers, for the case of parasympathetic nerves, they will always be short. So the short postganglionic fibers will be supplying the organs. Sympathetic fibers of the preganglionic neurons T5 to T9 segments come from the intermediolateral horns, come through the sympathetic trunk, and from the greater splanchnic nerves. They contribute to the celiac plexus, where the postganglionic neurons are located. Branches of the celiac plexus reach the liver, wrapping around the branches of celiac artery. Okay, got it. Moving forward to the point number 45, that is about the portal hypertension and the portocaval shunts. So there are three sites which are very important for the portocaval shunts, and I guess they've written all of them, all the three of them. So let's read them one by one. So portal hypertension is a common clinical condition, and for this reason, portosystemic anastomosis should be remembered. Number one, that is over here, extrahepatic portocaval shunts. For the treatment of the portal hypertension, we develop them ourselves. So for the treatment of portal hypertension, the splenic vein may be anastomosed to the left renal artery after removing the spleen. So we are removing the spleen, so we have to do something with the splenic vein. So we anastomose the splenic vein with the left renal vein. So there is a direct connection between the left renal vein to the portal vein and all that, right? Then we have intrahepatic portocaval shunt between the portal vein and the hepatic veins. This is called as the TIPS procedure. I don't know the full form of TIPS. Let's see that. What's the full form of TIPS? TIPS. Portal hypertension. So TIPS means transjugular intrahepatic portosystemic shunt. So a shunt is being formed between the portal and the hepatic veins directly. Portocaval shunt between the portal vein and the hepatic veins. Then metastases of the large intestine cancer typically reach the liver via the portal systemic veins. From intestine to the inferior mesenteric vein, then to the splenic vein, and then to the portal vein to the liver. If there is an obstruction to the flow through the portal system, portal hypertension, blood can flow in a retrograde direction and pass through the anastomosis to reach the caval system. Site of these anastomoses include esophageal veins, paraumbilical veins, and the rectal veins. Esophageal veins can develop esophageal varices. The paraumbilical veins can form the caput medusae, and the rectal veins can form the rectal varices or hemorrhoids, I guess. hemorrhoids. But remember the rectal varices. That's a good thing. Then esophageal anastomosis. Anastomosis between the tributaries of left gastric vein, portal vein, and the tributaries of azygous vein, superior vena cava, is the wall of lower end of esophagus is the portocaval anastomosis. In the portal hypertension, these veins enlarge in the wall of esophagus and later burst into the lumen of esophagus. They are called esophageal varices, resulting in hematemesis, vomiting of red blood, and that can be very profuse bleeding. So this is the site of development of esophageal varices between the left gastric veins and the tributaries of azygous vein that is connecting to the superior vena cava, and left gastric vein is a portal vein tributary. Umbilical anastomosis. The anastomosis between the paraumbilical veins, the portal veins, and the superior and inferior epigastric veins, superior vena cava and inferior vena cava, in the anterior abdominal wall around the umbilicus. In portal hypertension, this anastomosis becomes enlarged and dilated veins form caput medusae around the umbilicus. So this is the site, and there will be caput medusae. Caput medusae is like a lot of dilated veins around the umbilicus. Then rectal anastomosis. So anastomosis between the superior rectal vein that is coming from the inferior mesenteric vein and then the portal vein. So basically superior rectal vein is a tributary of the portal vein, and inferior rectal vein which drains into the internal iliac vein which goes to the inferior vena cava. So this is portocaval anastomosis. In portal hypertension, chronic alcoholics, for example, who develop cirrhosis, this anastomosis become dilated, resulting in the internal hemorrhoids and bleeding per anus from the superior rectal vein. Okay. Then we have pancreatic head and uncinate process. So this is the pancreatic head and the uncinate process. So let me draw it with the yellow color. So this thing is a pancreatic head, and then we have uncinate process like this, and then over there. So this is the head, and then we have the uncinate process. So the head of the pancreas rests within the C-shaped area formed by the duodenum and is traversed by the common bile duct. It includes the uncinate process which is crossed by the superior mesenteric vessel. Okay, so it includes the uncinate process which is crossed by the superior mesenteric vessels. So here you can see the superior mesenteric vessels are passing over the uncinate process. Then what is pancreatic adenocarcinoma? So pancreatic adenocarcinoma is a cancer of head of pancreas. It compresses the bile duct and results in the obstructive type of jaundice. Obstructive type of jaundice is any jaundice which is obstructing the flow of the bile that has already been formed. The non-obstructive jaundice is the one in which there is so much bilirubin in the blood that either the bile is not being formed adequately or the bile is not being formed at all. So we will see that basically we have seen that already in the GAT section. So kindly refer to those videos. But the pancreatic adenocarcinoma means that cancer in the head of pancreas which compresses the bile duct and results in the obstructive type of jaundice. Pain will be conveyed to the sensory neurons T5 to T9 dorsal root ganglia via celiac plexus and the greater splanchnic nerves. To provide the pain relief during the surgery, ablation of the sensory innervation carries ablation of the sensory innervation that carries the pain in the region may be performed by injecting 90% and 50% ethanol around the celiac artery. This type of jaundice is not usually associated with fever, and hepatitis also causes jaundice but is associated with a fever. So if hepatitis is causing the jaundice, since it is an itis, which means it is an inflammation, so inflammatory mediators will be causing fever. But if there is a jaundice that is due to the compression caused by the enlarged head of pancreas, that is due to the adenocarcinoma of the pancreatic head, so that will not result in a fever. So this is a good differentiating point. Then moving forward to the neck of pancreas. So this thing is the neck of pancreas. We're done with the head, and now we have the neck of pancreas over here. So posterior to the neck of pancreas is the site of formation of the portal vein. So portal vein is formed just behind the neck of pancreas by the merger of the splenic vein and the inferior mesenteric vein. Both of them will fuse together to form the portal vein behind that. Splenic vein joins with superior mesenteric vein and the portal vein. I'm sorry, superior mesenteric vein. I guess it is inferior mesenteric vein. No. It is splenic vein which joins with the inferior mesenteric vein, and both of them join with the superior mesenteric vein to form this portal vein. So these three veins are basically joining together in the behind the neck of pancreas. Okay. Then we'll talk about the body of pancreas. So this is head, and then we have the neck and body and tail. So the significance of the body of pancreas is that the body passes to the left of anterior to the left and anterior to the aorta and to the left kidney. So this is the right side, and give me a second. The right side, and now we have the left side. So the body passes to the left and anterior to the aorta and the left kidney. The splenic artery undulates along the superior border of the body of pancreas with the splenic vein coursing posterior to the body. So the splenic artery undulates along the superior border The splenic artery undulates along the superior border. Okay, so splenic artery is moving along the superior border of the body of the pancreas with the splenic vein coursing posterior to the body. Then we'll talk about the tail of pancreas, which is the terminal portion over here, like this is the tail. So the tail of pancreas enters the splenorenal ligament. So it enters the splenorenal ligament to reach the hilum of the spleen. It is the only part of the pancreas that is intraperitoneal. Tail of the pancreas may be mistakenly removed during the splenectomy, ligation of the splenic artery and vein, and resulting in sugar diabetes because it contains a lot of endocrine cells. So endocrine cells, like, they're clustered in the tail. So if you remove the tail mistakenly, so that can lead to development of diabetes mellitus. It is an iatrogenic kind of diabetes mellitus, and that will be diabetes mellitus type 1 because there is loss of islet cells, but not basically specifically diabetes mellitus. We cannot classify that as type 1 or type 2. It will be iatrogenic diabetes mellitus or sugar diabetes mellitus. Then we have arterial supply to the pancreas. So arterial supply, head and duodenum, both of these structures, like pancreatic head and the duodenum, are being supplied by the superior pancreatic or duodenal arteries, which are branches of the gastroduodenal artery. Inferior pancreatic or duodenal arteries, which are branches of superior mesenteric artery. This region is important for the collateral circulation because there are anastomosis between these branches of celiac artery and superior mesenteric artery. Neck, body, and tail of the pancreas, pancreatic branches of splenic artery. So neck, body, and tail are being supplied over here by the pancreatic branches of splenic artery. So they are supplied by the pancreatic branches of the splenic artery. Okay, so here you can see that the pancreatic branches are coming from the splenic artery, which are supplying the neck, body, and tail, while the head of the pancreas is being supplied by the superior pancreatic or duodenal artery and inferior pancreatic or duodenal artery. This one is coming from the gastroduodenal artery, which is a branch of celiac artery, and the inferior pancreatic or duodenal artery is coming from a superior mesenteric artery. Then we'll talk about annular pancreas. So annular pancreas is caused by the malformation during the development of pancreas before birth, occurs when the ventral and dorsal pancreatic bud form a ring around the duodenum, thereby causing an obstruction of the duodenum and polyhydramnios. Why will there be polyhydramnios? Because the fecal matter will not, what? Polyhydramnios? No. Let's talk about it. I will tell you about polyhydramnios as well. It occurs when the ventral and dorsal pancreatic bud form a ring around the duodenum. So you can see that the ventral head and the dorsal head, they are collecting together and they are forming a ring around the pancreas. They are forming a ring around the duodenum. So the pancreatic, ventral, and dorsal heads are forming a ring around the duodenum. The polyhydramnios occurs because the fetus cannot swallow the amniotic fluid, because there are only two things. The circulation between of the amniotic fluid occurs in such a way that the fetus swallows the amniotic fluid and then it urinates into the amniotic cavity, which will give a major chunk of amniotic fluid, and then it will swallow the amniotic fluid again. So this is the circulatory pathway. If the fetus, due to any reason, cannot swallow it properly, resultantly there will be polyhydramnios. Symptoms are feeding intolerance in the newborns because the food cannot pass through this segment, fullness after eating, nausea and bile stained vomiting because the I guess it is in the second part, so it is after the opening of the bile duct. The bile duct opening is there and obstruction is distal to that, so there will be bile stained vomiting, and half of the cases are not diagnosed until the symptoms occur in the adulthood. Point number 47 is about the spleen rupture of the spleen. So rupture of the spleen may result, it is most fragile organ of the abdominal cavity, right? So rupture of spleen may result on the left 9th and 10th rib fracture. So it is behind the 9th and 10th rib. So it is surrounded by that. If there is 9th and 10th rib fracture, it may result into splenic rupture or blunt trauma to the left upper abdomen. The spleen is a peritoneal organ in the upper left quadrant that is lying deep to the left 9th, 10th, and 11th ribs. The spleen follows the contour of the rib 10. So it is following the contour of the rib 10, that is axis of the spleen. When the blood collected deep to the diaphragm, that is phrenic nerve, irritates and pain may radiate to the left shoulder. When the spleen is ruptured, it cannot be sutured, therefore removing is required. So when the spleen is ruptured, it can't be sutured, therefore we need to remove it. Relations of the spleen and the left kidney. So the spleen follows the contour of 10th rib and extends from the superior pole of the left kidney to just posterior to the mid-axillary line. The border between the spleen and the upper pole of the left kidney is 11th rib. So here we have the spleen, and then we have the 10th rib, and the left kidney is over here. Over here there's the kidney and the spleen and the 10th rib. So the rib number 11 is over there. The 11th rib. Point number 48 is about kidneys, dimensions, and positions. During the life, Kidneys are reddish brown and measure approximately 11 to 12 centimeter in length, 5 to 6 centimeter in width, and 2.5 to 3 centimeter in thickness. They are extending from the level of T12 to the level of L3, and the right kidney lying about 2 to 3 centimeter lower than the left one. The lateral border of the kidney is convex. Its medial border is The lateral border is convex. The medial border is concave at both ends. It must be concave, right? The medial border is convex at both the ends. So if it is medial border, so the ends are convex. Like the end is convex, this end is also convex, but concave in the middle where there is hilum. It is concave only in the hilum. So the lateral border is convex. The medial border is convex at the ends, but the hilum is concave. Okay. Hilum of the kidney at L1 position. Okay. Anterior relationship of the kidney. So the anterior relationship of the kidney are right suprarenal gland. Okay, so right suprarenal gland will be located something over there. Then second part of the duodenum, the descending part of the duodenum. There is the second part of duodenum. We are talking about the right kidney, right? The second part of the duodenum, right lobe of the liver. The right lobe of liver is over there. Then the right colonic flexure. Okay, right colonic flexure and the small intestine. So these are five relationships of the right kidney. That is right suprarenal gland, second part of the duodenum, right lobe of the liver, right colonic flexure, and the small intestine. The anterior relationship of the left kidney are the left suprarenal gland, obviously, this gland over here. Then the stomach on the left side, spleen is on the left side, which will be located anterior to this kidney, body of the pancreas and the splenic vessels. I'm sorry, my mic was not very well connected. So then your descending colon and small intestine. So we'll talk about the renal garrota or fascia, renal garrota fascia in the next session. Until then, Allah Hafiz and Fi Amanillah.